I'm Ira Kirschenbaum. I am the editor of the Journal of Orthopedic Experience and Innovation. We are here with our third in a series of a spectacular Joey open mic topic session. This one is on the work of articular cartilage repair and osteotomy. We have a superb panel tonight, and I'm going to have them introduce themselves. Let's start with Kevin Freedman.
Hi, I'm Dr. Kevin Freedman. I'm a sports medicine orthopedic surgeon with Rothman Institute in Philadelphia, primarily working out of Bryn Mawr and Chalfont area.
Excellent. And Justin?
Hey everyone, I'm Justin Mitchell. I live and work in La Crosse, Wisconsin at Gunderson Health System. I'm a pool team physician for the U.S. ski and snowboard team. Excited to be here.
Excellent. And Joe?
So I'm in my 20th year of practice. I'm just north of Boston. I trained at Jeff and then the Harvard program and serve as the director of the Cartilage Care Center at Excel Orthopedics. I'm very excited to be speaking with everyone here tonight.
Excellent. So I think, Joe, you're going to lead us off with a little bit of discussion of just the disclosures and the ISI of the drugs and get that compliance out of the way. And then we're going to go full force into our topic.
Great. Thank you so much. Looking forward to the spirited discussion we're going to have. So just a few housekeeping things. One is that all speakers are paid consultants of Vericel and that nothing said in the session constitute direct medical advice. And another important factor is just that MACI should not be used in patients who can't follow a doctor-prescribed rehab program after their surgery. Next slide. And so indications, MACI is an autologous cellularized scaffold product indicated for the repair of single or multiple symptomatic full thickness cartilage defects of the knee with or without bone involvement. And its safety and efficacy in patients over 55 or in joints other than knee has not been fully established. And we'll discuss the use and dosage during this program. Next slide. And so it's important contraindications, very rare, but in patients with a hypersensitivity to gentamicin, other aminoglycosides, or products that are made from porcine or bovine origin. This is not for severe osteoarthritis or inflammatory arthritis, inflammatory joint disease, or uncorrected congenital blood coagulation disorders. When doing a MACI procedure, you really should only do it in patients that have not had any other prior knee surgery within the last 6 months, unless that was to procure a biopsy or a stage procedure to prepare the knee for implantation. So next slide. And so adverse reactions, those serious adverse reactions that are possible are arthralgia, tendonitis, meniscus injury, treatment failure, osteoarthritis. And in general, it's not recommended during pregnancy, and its use under age 18 or over 65 has not been fully established in the literature. Next slide. So where is the lesion located? So articular cartilage repair with MACI requires careful assessment of that location, the size of the defect, and also identification of any concomitant pathologies that may need to be addressed. Next slide. So pathologies, the kind of the three main things that really have an impact upon our decision making are meniscal injury or insufficiency or deficiency, malalignment, and ligamentous instability. And addressing those are important. And we've definitely seen evidence that addressing those concomitantly will help preserve the integrity of the primary cartilage repair and eventually improve the patient's ability to get back to their desired outcomes. Next slide. So we're going to see some concomitant procedures today. Most commonly utilized ones are TTO, also MPFLs, trochleoplasty also have come on recently, and then partial meniscectomy, meniscal repair or allograft, and then ACL revision or reconstruction is some options. And sort of the big trifecta again are these concepts of alignment, stability, and meniscal integrity, just to be able to address these comorbidities either before the surgery or at the time of the MACI repair are going to help with patient outcomes and durable repair. Next slide. And so It's the same MACI. There's two now surgical techniques. We have, in general, it's indicated for adults that are reasonably active, moderately or significant activity levels, ages 18 to 55, with symptomatic full thickness cartilage defects of the knee, with or without bony involvement. And we prefer that they have a low to medium BMI, and that any concurrent issues are addressed at the same time and they can comply with the rehab. For the open MACI, certainly for as little as a 2 centimeter square defect to, much larger than that can be treated. And certainly if you can do any open procedure, that would be the route. Now with the evolution of MACI arthro, lesions up to 4 square centimeters can be treated arthroscopically, and it's especially helpful if you're going to do other procedures arthroscopically at the same time. Next slide. So there are wonderful tools that are developed to help facilitate the ease of implantation. From an arthroscopic perspective, we have 4 customized cutting sizes there and various cannulas that will help with preparation, as well as the V shuttles. There are a couple sizes for that. And for the open techniques, we have the 7 different cutting templates that help create the sharp vertical shoulders that we're looking for, and they have precise fit. And as a consequence of using those, there's no need to template the implant, which can save you a shortened surgical time. And there's also minimal handling of the tissue. Next slide. So today we're going to go over, my case is MACI and also concurrent TTO. Next slide. You can run that. So I apologize in advance with this. We did have some technical issues, and some of the osteotomy video didn't save. There's no Harry Potter wands to just magically make the osteotomy happen. It won't all be there, but we'll narrate a little bit through it. A couple important points I wanted to reinforce. One is that with appropriate nerve blocks and patient counseling, patient expectation setting, obviously these can be safely done as outpatients. We haven't done any of these, even with TTOs, DFOs, and HTOs. We've done them all as outpatient for the last 14 years now. When I'm thinking about when do I do the osteotomy, when do I do the cartilage work, in general, if I have to go into deep flexion, I'm going to want to do the cartilage work first so that I don't end up stressing my osteotomy. In this case, we're doing patellofemoral, and so that we're not worried about manipulating the knee into upper position. So we started off with the osteotomy. You're going to see a couple different techniques. I like to do it open, and I like to do it freehand. And so you see us exposing the skin and subcutaneous tissues, and then we're going to liberate the anterior tib there. And so we'll first do that, and then we'll come to the posterior border of the tibia. I want to be able to see that. And then I'm going to end up then delineating the medial aspect of my osteotomy just adjacent to the patellar tendon. That's my medial starting point. And so I'll delineate that, and I try and make a relatively long cut because I do want to have a reasonable surface area. And again, I want to maintain that distal hinge. So I'll place a pin approximately 1.6 or 1.8 millimeter guide wire, place it in place from kind of anteromedially, and then going towards the posterolateral aspect of the tibia, and then tapering that upward as I come higher. And that becomes functionally my guide. And I end up using like a falcon blade, or just, there are a couple of different brands that are made that have an internal control, so I can hold my osteotomy blade and just the distal end is working. And so then I can be very careful with how I do it. And so I'll do that. I will make my crosscut. When I make the crosscut up top, I want to be cognizant of obviously the patellar tendon attachment to the tubercle. I want to know where that is. I want to be cognizant of the joint line, and I want to be below that. And I also want to be cognizant that when we shift our osteotomy, we don't want to end up having it be incarcerated. So you want to make sure that it's free to move by placing an angle to it. So, and then we'll end up connecting it along both the medial and lateral aspects so that it's relatively free floating. We'll use a bigger osteotome to kind of lever it and make it crack. I usually shift it over 10 millimeters, about a centimeter, and then hold it in place with a Kasdan. We'll use some screws that are overall flat-headed and lower profile, and we countersink them. And then when we're finished with it and satisfied with it, then we'll go ahead and we'll put some corticocancellous graft to just help facilitate it. And then I'll put a little DBM putty, mostly just to snug it in place. And then we'll put a little, a little pixie dust. We'll put some vancomycin powder at the end just at this. And so there's a lot of ways of handling the anterior tib fascia. I try not to over tighten it. I don't want to get a compartment syndrome. So now we've finished with our osteotomy. Now we're starting to expose the knee joint. We don't have to do a Z lengthening. It's not a lateral tracking issue. It's more of an offloading that we want to anterior medialize this. And so we're just exposing the capsule, just making sure not to cause any articular damage. And through here, most of these that we're going to see, or not most, but many of these that we're going to see are going to end up having had prior surgery. And this one, there's this huge band of adhesions. Just she had a prior ACL, this patient, and so we wanted to lyse that so we have adequate mobility of the patellar tendon. And when one of the things, just I've learned over time to try and preserve my joints. So rather than use the hooks to hold the capsular tissue on the patella, we'll create a little pocket that you see right here on the patella, and then we'll place a guide pin, two guide wires through it. If it's blunt on your end that's exposed, you don't have to put anything on it. But if you have a double sharp one, then you can just put a pain cap that you'll have from one of your handsets. And for this makes it much easier for me or the PA that I work with, Nicole, to handle, to just bring the patella into eversion so you can really work on that and it's nice and secure. You're not over gripping with your CMC joint. So this is just firing those two pins into position. And so now we have adequate exposure. We can see that the patellar defect, is definitely an issue and needs to be addressed as well. And then we're also going to see here that we have the trochlear defect, and that was kind of the one that drew us into it. One of the really nice things are with these cutting templates that we have, they're very sharp and they really help with creation of those vertical shoulders. When we place it in place, you can use a mallet. I end up putting one side in and make sure that's exactly where I want. Put it in place, push it in place, and you hear like an audible crunch. And then I'll bring it to the other side and I'll make sure I kind of get it. And then I'll work from the edges. And a lot of it's like a supination or pronation type of moves, like hooking onto the edge where we've demarcated with our cutting template and bring it to the inside. So I'll work around the perimeter first, and then I'll kind of end up working in the middle. This person is a little bit older in her later mid to late 40s, and so sometimes the bone is more fragile, and you get into a little bit of punctate bleeding. We're careful. We try not to, be too aggressive with it. But there's just some areas, and the trochlea, it's not unusual to get a little punctate bleeding, and I'll show you how we contain that in just a moment. So just finishing up with it. Another thing, the little trick that I use is just have a specimen container and put some saline in it. And then after you're doing your curettes, then you can just dip it in there and kind of shake it. And then it's all of a sudden really free. And once I've had it adequately prepared, then we'll dry it off with a sponge. And then we'll take little patties that are soaked in thrombin, and we'll put the thrombin soaked patties into position. And in this one, there was a little bit more blood. And I'll show later how we also take care of that. What I could just mention it now while we're looking at the patellar lesion. But if there is a little punctate bleeding, I try and stay away from electrocautery on the bone. I don't want to cause any necrosis or damage to the bone. So what I'll do is I'll lay fibrin glue there. I'll wait about a minute until it like quasi-gelatinizes. And then once that's the case, then I'll push it in place. And then it does a really good job of plugging the bleeding. So we'll finish that later. Now with the patella, again, it's stabilized because we have we have those two guide pins that hold the patella. We have a very good exposure. Kind of rock it on one side after we've lined it up, and then rock it on the other side, and then just make sure that we have those vertical shoulders. For panpatellar lesions, there's a broad circular guide as one of the 7. But you just pick whatever seems to work best, and if it doesn't seem to be the right fit, then you can just create it and kind of freehand it. And then again, the same principles, like kind of supination, pronation, starting from the corner, bringing it inward, and then just being careful not to get into the bone, but wanting to kind of make a full debridement. And you can see the patellar bone in general is much harder. And unless they've had like a prior microfracture, you usually don't end up getting into as much bone bleeding with the patella. But I mean, get a sense with the patella that like really what remains is from healthy cartilage. Take another thrombin soaked patty into place there. And then before we go ahead and do our implantation, like all this I've done like under tourniquet and taking care of hemostasis as we go. But then now I let down the tourniquet. One thing also to remember is if you're doing one of these in flexion, when you bring the knee to extension, it will end up bleeding a bit more. So, this takes several minutes where you end up kind of getting hemostasis as you're working, but it's important to make sure you identify any bleeders right now and kind of have the majority of it taken care of. And then once we have, some reasonable hemostasis and we're satisfied with that, then we can start to think about during implantation. Just, we double check what it do is like just sometimes just bring the guide back in as a double checker just to make sure I have that fully debrided. And then this is where I was telling you that we put some of the fibrin glue just a little bit in place, and then we wait about a minute, and then we push it in, just hold it in place, and most of the time that does the trick. And again, especially post microfracture, if somebody's a little bit older, then you're going to end up seeing potential for bleeding with that. So when we're satisfied, and I'll cover it up, and then we're going to, just so it doesn't desiccate in the lights, and then we'll go to the back table, and then we'll go ahead and get the Macy membrane. So, little tips and tricks, we have them dump off about a third, like a quarter and a third of the fluid, and then just get it swirling. So it's important to kind of get the membrane moving, and then just to kind of dump it out quickly. And then when you're taking it out, so one of the ways to remember is we put the notch on the lower left. And when the notch is on the lower left, then the cells are up. And then the shinier side, which is going to be kind of the articular side, is on the back side, which I just reflected to show down. But this side is like, when you look at it closely, is a little bit more on the rough side, and that's the cellular side. So this is one of those guides. This is the same guide that we use for the trochlea. And so we're putting this in place. I line it up and make sure I have perimeter, like, don't box yourself in. Don't go right in the middle with the sweetheart one. Like, go close to the edge, and then we'll kind of tap the quadrants. We'll kind of penetrate one side and then the other side, and then each of the two other sides, and then we'll kind of like tap it around, and then we'll go ahead and we'll lift it up. And so when we lift it up, you can see that we have the guide is there, but then the rubberized base layer is being stabilized so it doesn't lift up. And then we lift it up there, and then I'm sorry for whatever, this is just showing up a little bit choppier than how I'd filmed. But so now we have it and it's free. And then we'll go ahead and we'll do the second one there too. So we have one. Again, I don't want to cheat myself. I kind of put it into a little nook, so if something happened, I could still grab another one or two membranes from it. And then we do repeat the same process with it. And we make sure that we're cut through. You can lift it up and over with the forceps and make sure it's in place and make sure everything's moist. And then now we put the layer of the fibrin glue in. And so, kind of less is more with this. If there's any kind of use gravity or advantage, start at the top and then work your way down. Bring the membrane over just carefully. And again, remember that the cells are up when they're there. And so that you'll deliver them so that the cells then go down. And then we've also learned over time that you don't have to keep your finger on it for the full 3 minutes. So kind of press on it to make sure any bubbles are gone, no pockets or folds there. And then I just let it sit there, and we time it for 3 minutes. We'll put a little bit of glue on our hand or like on the leg, just make sure it gelatinizes too. And then after we're happy with that, then we'll seal the perimeter, and we'll give it 3 minutes for that to also seal. And this is just clearing up some blood that's just like gradually making its way. So in general, I usually would tend to, because I worry more about the patella. Like if I were to do the patella first and then it was like in the way or being retracted, I just don't want to bother it. So in general, like I'll tend to do the trochlea first, and then we'll do the patella. One of the beauties of Macy is you don't have to put sutures in. I grew up doing this as ACI with periosteal membrane was how we first started doing it. So I'm used to putting some sutures in it. So for me, I just like, if it's bipolar, then I'll go ahead and I'll suture the patella. It's not a required thing. I just put a couple stitches in it, and you can be expeditious with it. And it's just like a 6-0 Vicryl, and it's dipped in mineral oil so it slides through. You just be careful when you go through, after you go through the membrane, when you come through the cartilage, that you're at the base of the cartilage. You don't want to come up in the cartilage and then make the membrane trampoline up. So once we've had it secured, and then we did our perimeter line of glue as well after we did our sutures, then we'll remove our guide pins, and then we'll check for stability. So we'll bring the knee back over, and then we'll put it through our range of motion and make sure that the membranes are stable. If we want to see any kind of like puckering now, we want to identify it right away. And so that's essentially how we end up doing it, and then we end up closing it. Put a couple, usually like an apical one, just at the superomedial aspect of the arthrotomy there, and then we'll just do some running limbs as well. And after once the joint is sealed, then we'll put a little bit of Vanco powder in there as well, and then I'll infiltrate a little bit more of the. For this, we also use like an Exparel that we infiltrated at the beginning of the case, and then we'll put a little bit just at the very end, and again, just helps. So we just putting that into position and then seal it. And for these, I use non-absorbable sutures like a monocurl. So thank you very much. I'm looking forward to seeing the other colleagues present theirs.
That was great, Joe. Justin, you're up.
Great. I'm going to be piggybacking off a lot of what Joe said, and so I think we'll get right into it here, so we can go to the next slide right away. So I'll give you a little bit of a patient vignette here. This is a relatively young female, 28 years old, has a normal BMI, but interestingly, she does have a history of a gastric bypass. Even though she's 28, this was, believe it or not, kind of in the remote past. So she's been kind of living at a normal BMI for a while. So I think we can take that as for what it is. She works as a pharmacy tech. She's not a smoker. She works mostly a seated job as that pharmacy tech job. But she's pretty active now. She enjoys a lot of outdoor activity, hiking, recreational pickup, basketball. Basically an atraumatic injury, but she did have one acute event in high school, which she kind of says caused this whole thing. So let's go to the next slide. So her original pain began with that injury in high school, according to her, but as we talk more, it seems like it's more atraumatic, kind of waxing and waning off and on for about 10 years. She hasn't had any recurrent injuries that she recalls, but she did have this kind of odd history of a previous knee scope in high school with a plica excision. You know, all of our favorite things that happen with these patellofemoral surgeries is they get a plica excision or some sort of lateral release, and then they fall in our lap, and then we have to figure out what's going on. She wants to return back to recreational sport and outdoor activity, and her goals are really to basically live a pain-free life and do all this as much as possible. So next slide. So when I saw her, she obviously was complaining of pain in the anterior knee. She had a very, very slight lateral patellar subluxation. Not a lot, very slight, little bit of an effusion, but normal range of motion. The knee was otherwise ligamentously stable. She had that prior surgery, as I previously mentioned. And interestingly, she has this sensation of constant crepitation, anterior catching of her knee, and obviously daily pain. Next slide. So when we look at a radiograph, not much exciting that we see here. If we focus in on that right side, ever so slight lateral patellar subluxation, maybe a little bit of abnormality that we can see on the radiograph, but certainly nothing overly exciting. Next slide. So when we look at her MRI, we see similar things. Now this is hard to discern, so I'm going to give you a couple actual video slides in the next one. But if you look carefully at that axial image on the far left, you can see there's some hint of an injury to the articular cartilage on the most lateral aspect of the patella. And then on that sagittal image, you can kind of see the same inferiorly. And then in the coronals, you can catch kind of that there's some areas where the cartilage doesn't look totally normal. So let's go to the next slide. Yeah, lots of arrows to show you. So the next slide, we can kind of see this a little bit more robustly. You can see as we get to that inferolateral aspect of the patella, there's clearly an area that's abnormal. There is a little bit of subchondral bony edema. So I always use that as a marker of whether or not this is actually taking load or causing friction. If we see that subchondral edema, that's a pretty good indicator that there's load there in that area that could be causing some pain. Her tibial tubercle trochlear groove distance, a little bit increased, not dramatically increased, around 14. So let's go to the next slide. So again, we're looking at our coronal here. You can catch that inferolateral cartilage lesion on this coronal right about there. You start to see it. And again, you see that subchondral edema. And if we click one more time, we'll be able to see the slides through the sagittal view. And you see that inferolateral cartilage injury. So this is a patient who's had a history of a previous surgery. She's very active. She's got crepitation that we can actually feel on exam, and she feels it subjectively. She feels a click in that area. At this point, I think it's very reasonable to look at this a little bit further. She's got all the right symptoms and an MRI kind of matching that. Next slide. So we did go forward with a diagnostic arthroscopy with plans to evaluate her chondral lesion. So the image on the upper left there, where there's some sort of blood within the articular cartilage, I think is always interesting because I think that tells me that there is some reactivity here. There's something that the body is reacting to. There's blood accumulating in the crevices of the injured cartilage, and then as soon as you start flushing that out, immediately you see that that cartilage kind of separates. So I don't know if that's the body trying to heal that in or what's going on there, but there is definitely some body reaction to that cartilage injury. And then when you flush that through, you see immediately the fibrillation of the cartilage, and then click one more time. And then once we actually are able to clean up the cartilage, you see that cartilage is quite a bit more damaged than we think once you start clearing it away and realizing the extent of that injury. She's got a functionally focal grade 4 lesion on that inferolateral aspect of the patella, and you can actually see exposed bone in the very central aspect of this. Next slide. So at this point, her meniscus was intact, her other ligaments were intact. She's got that single inferolateral patellar lesion, which I would call grade 4 functionally throughout, even though the only one area of the bone is exposed. The rest of that cartilage is certainly not good. And the opposing surface or trochlea in this instance is intact. One more click. And so the surgical plan at this point, obviously we wanted to do a MACI biopsy. We want to stabilize the lesion. And then we're talking about the possibility of a second stage tibial tubercle osteotomy. She's got no true instability, so I don't think we need to do anything to stabilize her patella. But I think this is an important conversation. I think Joe hit on this very nicely, is that when we're looking at isolated or patellar lesions, trochlear lesions, or obviously bipolar lesions, there is reasonable data to suggest that MRI findings after surgery and patient-reported outcomes are improved by offloading these cartilage areas. So this is something I think we need to actually think about a little bit. Even though this patient doesn't have significant lateralization of her patella, and even though this patient doesn't have any true patellofemoral instability, certainly she has chronic anterior knee pain. She has what I would think is likely a chronic chondral lesion. She's got some subchondral edema, so there's some increased force in that location. Plus, we have this good data suggesting that there's increased in patient-reported outcomes and increased MRI findings, which we know correlate to patient-reported outcomes with offloading the patellofemoral joint. So I think this is a really good discussion of, hey, not always do we have to have definitively or crazy abnormal anatomy, or do we have to have true instability to consider offloading procedures to help protect our cartilage repairs? Because my thought process is always, we want to do the cartilage repair once, we want to get it done and have the patient move on with their life. So in this instance, I felt that it was very reasonable to consider a tibial tubercle osteotomy to offload and protect our cartilage. So next slide. So intraoperative imaging at the second stage here. So you can see the body tries to do something. There's a little bit of fibrocartilage filling in there, but certainly not enough to restore normal cartilage. And this is, what we see a lot is that people oftentimes think that fibrocartilage does this great job of filling in these lesions. Well, that's not always the case. And we can see that if you do more and more of these second look MACI procedures, you can see this quite frequently. So we confirm the lesion is exactly what we thought it was. Next slide. And then we start our procedure. So I think you can do a little bit of dealer's choice, as Joe said, as far as what you like to do first versus what you like to do second. I think in this instance, I like to expose the patella to make sure I've got excellent patellar exposure. Now, Joe mentioned the idea of hemostasis, and I think that's something that I take very seriously. As you can see here, I actually do like to destroy my PA's CMC joints, I guess. We use the hooks. But you can see, even with the limited incision here, you can get really nice exposure. And I do this in the name of hemostasis because really we want to make sure we want to keep as much blood out of this field as we possibly can. And even with this limited exposure, you can see I get very nice visualization. I can very clearly see our lesion, and I can use our 3.9 guide here to actually fully circumferentially encompass the lesion. Now, what you're going to notice is that as I'm doing this, I actually will score the patella bone just a little bit. You can see that on the very inferior and lateral aspect of the patella there. So I'm going to use Joe's trick that he talked about. You can actually use fibrin glue to get that hemostasis that you desire. So if you accidentally impact that a little bit more firmly than you think you should, you can actually just cover that up very nicely to get hemostasis. So what I'm doing here, obviously very similar to what Joe showed, is preparing this lesion. We've got a very nice circumscribed, well-contained lesion on the inferior and lateral aspect at the thin rim of cartilage, but it's there. And then I'm going to show you that fibrin trick that Joe mentioned, just putting fibrin in that, letting it seal in and pressing it down. So next slide. So At this point, obviously, we've done the Macy biopsy. We're considering the tibiotubercle osteotomy. We've defined the defect. It was 22 by 22. We were able to use that 3.9 centimeter squared oval guide to completely encompass that lesion, and now we're going to do that TTO. Next slide. So my preference is obviously prepare the lesion first, which I've done. You can see that very nicely. Next slide. And now we're going to actually go to our tibial tubercle osteotomy. So again, in the name of hemostasis, I actually create a separate incision. Now, the bridge between that skin is not dramatic, but when you close it, it actually looks a lot bigger than it looks here in the imaging. And I do like having these as separate incisions for that exact reason. And as long as I can see and work and make sure I have good visualization, I think this is very reasonable. Now, don't do this in the in the name of visualization and not get good visualization here. So we want to make sure we're getting that. And the thing that I would point out is a little bit different than what Joe does, especially in these cases that are not instability cases. I really want to be sure I'm not overcorrecting this or not getting my angle in a position that I don't like. So I will actually use the AMZ guide here to make sure I'm getting a 45-degree angle and make sure I've got a bone block that is the appropriate size that I like. Now, is this absolutely necessary? Obviously, Joe showed you a very, very elegant surgery where it's not necessary. You don't have to do this. I will admit there's a bit of neuroses here, and I want to make sure that I'm doing it exactly the way that I want to and getting the exact angle and movement that I like. So I have a tendency to use the guide here. So all of the steps that Joe showed as far as exposure are essentially similar. The only difference here is the guide. He mentioned the saw. Again, I like to use that end oscillating saw. I like to use a fully closed tip saw. I don't like the ones that have the slots in them, and the reason I don't like those is because they can more easily break. So I like to use a nice solid saw there. And then we're just using osteotomes to free our osteotomy, moving it over 10 millimeters and provisionally securing it in place with guide pins. The thing that I like to do here is I like to use headless compression screws if I can. And the reason that I like to use headless compression screws is because our rate of hardware removal has gone down significantly by using those. And that allows me to actually get three nice screws in there to compress this bone against the tibia, which non-unions in these settings are disasters. So I do like that compression there. Next slide. And then we go back to our Macy implantation. And so exactly to as Joe talked about, we got that cutout corner in the lower left. If we keep that in the lower left, that keeps our cells in the appropriate orientation. And then what I'm going to show you here is that if you use the guide, you can actually get several cuts out of this, just like Joe mentioned. So you can put this in different orientations, and based on the size of our matrix, you can actually get several different options out of that. If you screw one up or if you accidentally hammer in a way that you don't want to hammer, you can get multiple different implants out of this. So just as Joe talked about, I'm just leveling that down to the notch to make it even with the plastic membrane there. I'm sorry, with the rubberized membrane, and then basically peeling that off of there to give our nice implant, our nice oval implant there. So right now we're now going back to the surgical field, making sure that everything looks dry, making sure we have excellent hemostasis. Just like Joe said, this is a time where I'll put the tourniquet down, and you'll see here that even with the tourniquet down, you can see bleeding from the wound edges, but really not significant bleeding. And again, I think that's why I like these more limited incisions. Again, putting a small amount of fibrin glue on the surface of the patella there, and then flipping our membrane into the appropriate position and just doing a little bit of gentle manipulation to make sure it sits exactly where we want it. Again, we don't have to keep our thumb on this for the full 3 minutes. We can use these little dabbers. We can just give it a little bit of gentle pressure. And then one trick that I actually really like is to take it, once this dries a little bit, we don't want it to be super sticky, but once it dries a little bit, you can take a Raytech or a lap, just press it down. That really does dry it out, allow you to give a little bit of thumb pressure, keeps the membrane right where you want it, but also make sure it's nice and dry so you're not trapping any blood or any fluid underneath there. And then in the end, we're sealing the edges with our fibrin glue. So we get a really nice implant there. At this point, now we've got our tibial tubercle osteotomy completed. We've got our implant in. We've let things dry and seal. And now we're going to go through range of motion. I think this is really important. We want to check this. We don't want to go blind out of the OR. So we want to make sure this is nicely stable. And we're going to flip that back over and look at it, make sure it's staying exactly where we left it, which it is. And we can say that we've nicely completed that. So I think this is a really interesting case. And I should mention in the end, obviously, we do bone graft in the same way to make sure that everything heals the way we want it to. So next slide. In the end, we've got this very nice Macy implantation that really fills that defect very nicely, really fills in that space very nicely. And you can see that's recessed with the cartilage to make sure that's nice and stable throughout early range of motion. Next slide. And then just a quick image showing that we do check this with fluoroscopy. I think that's important. You can see the correction very nicely. Make sure that you've got the screws where you want it. I have a tendency to put that top screw a little bit angled down so that it compresses that top portion of the osteotomy a little bit more, but you can see the other two are nicely parallel. And then you can actually see that shift anteromedial of the osteotomy, which you can see nicely on X-ray. Next slide. So in the end, the patient here are her 3-month radiographs. You can see again, I think the importance of bone grafting, where you can actually see that that bone does start to heal in already, even by 3 months. The rehabilitation follows the standard rehabilitation protocols. I'm a little bit less aggressive with osteotomies. I like to keep them a little bit more limited at first, as far as range of motion, to not put stress on the osteotomy itself. But by 3 months post-op, I want to make sure they have full range of motion and are essentially walking normally with good quad activation and good quad function. Next slide. So that's our case. I'm gonna flip it over to Kevin, and he's going to talk about his case as well, which is a little more instability. And I want to thank you guys for coming tonight.
That was
Before
great, Justin.
Kevin, there was a question that was passed over to me privately in the audience. Might as well ask it now. We're going to ask the panel, do you always do a TTO with a Macy or only if the patient is otherwise indicated or only lateral inferior patella lesions? That was a question that was passed over by a participant. Justin, you want to field that, or Kevin, you want to field
Yeah, well, I can answer from my perspective, which is at this point, you almost have to talk me out of doing an osteotomy in a lot of these. Now, not every single patient should be indicated for an osteotomy, in my opinion, but especially those inferolateral patellar lesions, and most of those will have that subchondral, edema, and to me, that indicates some increased pressure in that location or some increased load. So I really do osteotomies in almost all of those. If I see that subchondral edema, I'm much more likely to do it. But I have a lot of discussions with patients about, hey, listen, here's the thing. A failed cartilage restoration procedure to me is a disaster. So I would rather be careful from the get-go, offload most of these, and go from there. But if it's truly a more acute, more traumatic injury, where we can't do some sort of a repair, you can make an argument not to do an osteotomy. But many of these more chronic lesions, I have to be talked out of it. I don't know if that's the right answer, but that's my answer.
Yeah, I
What,
also
what, go ahead.
I was going to say that, for any either central ridge or lateral facet defect on the patella, I am doing a concomitant osteotomy to unload as well. Now, obviously, in instability cases, there's a secondary purpose of, correcting the TTTG, but for just a patellar cartilage defect itself, it's not about TTTG for me. It's about unloading that patella. Now, obviously, we haven't really talked about condyle defects. That's a little different. And, in that case, we really are looking for that malalignment on long leg alignment films. And if they don't have it, I won't do an osteotomy. But for the patella, I'm very aggressive about it.
I would second what both of you said. I much more often am thinking I'm going to do an osteotomy with these, especially if it's a maltracking, definitely if it's bipolar, if it's a broad defect. If it's a single defect, then there certainly are circumstances, but I do kind of talk myself out of it, like anticipating that we're going to need an osteotomy. But you have to listen to the patient. I had a patient that we saw yesterday that, or we actually did today, we did his scope and his biopsy, that just with his religion, he kneels and he doesn't want to deal with the irritation of the potential of the osteotomy. And so I feel like with him, we could still get a reasonable correction of his patellar instability with an MPFL and doing a MACI. And that my ideal would have been to do it with a TTO in him, but I respect his wishes, and I think it's it's obviously very individualized.
Dr. Pope, you had a question. If you want to unmute and ask your question, otherwise I'll ask it for you. Okay, Dr. Pope's question was, why use a 45-degree cutting block compared to 60 when the TT/TG was normal, or is it 45 for everybody?
Yeah, good question. My answer is it's almost 45 for everybody. So I'm trying not to overly anteriorize people. I think that if we talk about irritation, That is one way to get people more irritated, is to more readily anteriorize them. So if you do a steeper cut like a 60, you're more anteriorizing them, and so they get more irritability. So you can split the difference with a 45. That's kind of been my go-to for that. Again, that is a little bit dogmatic, but I believe that that is a little bit less irritable if we're not anteriorizing them quite as much.
Excellent. Kevin, you're up.
Okay, thank you. So I'm going to present a case of patellar instability acutely with a cartilage defect that required a concomitant TTO, lateral lengthening, and MPFL. So is this video playing, or am I supposed to play it? So this is the arthroscopy. This is a patient who's a 32-year-old acute patellar dislocation. And you can see the significant articular cartilage injury to their patella going all the way from the medial facet, central ridge, into the lateral facet. I mean, it's really, about a 20 by 25 defect. They had an acute unfixable full thickness cartilage piece with no bone attached. And so this kind of shows this in the intercondylar notch. And this can actually be used for the biopsy. So this is a patient who needs not only a realignment, but a staged cartilage surgery. So I take the biopsy. I do, this is a maximally invasive surgery. I didn't think I was maximally invasive till I see these other guys try and make these other windows. This kind of operation, I don't try to do through a small incision. And also, I think the ordering, as you see from the other guys, can be a little different. So I do my osteotomy first. I know exactly what I'm doing in this operation, so I want to just do it in the order that makes sense to me. I'll expose the anterolateral compartment musculature. I use a cob to bluntly take down the whole muscle sleeve. So you saw that Joe was using a bovie. I don't touch it with a bovie. I just, go right on bone and put in a retractor. I also protect the patellar tendon edges for doing this. And, I like being able to see this completely. And especially knowing I'm doing a lateral lengthening and an MPFL. That's why I don't try and make these small windows. So I expose the two patellar tendon edges to protect it, make sure I can go right under the patellar tendon edge for my osteotomy, and I do remove a little fat pad. This is also the AMZ guide from MyTech, but I'll tell you, I just like freehand place this at the angle I want, and I do dial in my slope based on what I'm trying to do. So in instability, I'm trying to match medialization with anteriorization. If I'm really trying to anteriorize somebody, I'll go way to the back of the tibia. So the first thing I do is I set this with the drill bit and a guide pin. It really helps me know what kind of slope I'm taking as I look to where it's going out the lateral side of the tibia. And then once I set this, I can use the drill bits to adjust it if I don't like it. And then I do use a saw to complete this, as well as osteotomes. Now, unlike the other guys, I use this to my advantage in this kind of case. So I'll flip the whole patella up as needed to expose the defect. I know people talk about keeping it attached distally. I honestly haven't found it to be a problem at all to detach this and flip this and then reattach it at the end. And I'm going to use a lateral lengthening approach for the cartilage defect. So I usually move it about a centimeter like the other guys, but I don't reattach it at this stage. So for doing the lateral lengthening, I go basically to the superior pole of the patella, and I'm really delaminating the lateral side. So essentially make a small layer and then start to use my 15 blade to be above the synovial layer so that then I can lengthen these tissues for my reattachment. And as I said, for this case where I'm doing an MPFL, I like to use this as my exposure to the patella so that I leave that whole medial tissue sleeve intact for when I go to do the MPFL. So you can see I still have a synovial layer, and then I use a 15 blade to open that up. And I do then come right into the anterior compartment underneath the patellar tendon and be able to flip the entire patella. Now, obviously, if I'm doing a case that's not as maximally invasive, you don't need to do this, but this allows you to completely expose this without any difficulty. Now, you're going to see that I old school this. So I use a 15 blade knife to outline the defect. I don't use the cutting guides because I think this allows me to just take exactly the amount of cartilage I need to take. So use the ring curette just as mentioned. Just make sure I have nice, stable vertical borders. And the other thing is you do have to inspect the bone. So I had a little area of sclerotic bone, so I do sometimes use a burr for that as well. Measure the defect, because if I don't, my rep will yell at me and say I didn't measure the defect exactly. So I got to make sure I do that. Then this again is an old school technique. I just use glove paper to measure the defect. I outline it with a marking pen, and then I use that to make my foil template. So I know eventually I'm going to use this to have the colored part of the foil mark the cells being cell side up. So I just use that glove template to make my foil template, and then I just check it. At that point, we do take the tourniquet down. I, again, use thrombin-soaked gel foam with somebody's thumb in it. Again, you'll see a lot of this, just like the others. I don't have the cutting block, but I still orient that implant so that the notch is inferior. I use my template to cut it, and then I take that off. So it does require a little pressure on the graft when you're cutting it. But now my cells are up, and I know that I need to flip that when I go to put it in. We already have achieved hemostasis, use the fibrin glue. I make sure I flip the implant because the cells right now are facing up, and I know that I have to switch it. So once it's in place, I actually use a little peanut to compress it. So we saw the other guys using their thumb. I use this to compress down to the fibrin glue and then use my additional glue. Also, depending on the size of the defect, I will sew in the periphery. So again, this is 6-0 Vicryl. I'll sew the 4 corners. I don't do this all the time, but if I have a big defect, I will. Now, before I do the MPFL, I now have to fix my osteotomy because otherwise you're not going to be able to tension the MPFL appropriately. I also switched. I used to use 4-5 screws. I now use 3-5 fully threaded cortical screws that are over drilled on the proximal piece. I usually use a drill bit to hold my osteotomy position and then complete the other 2 screws. I found that since I switched to 3-5 screws, I haven't had to remove them. I used to have to remove the 4-5 screws a lot. And then I also got to close my lateral lengthening. So again, I have to do all of this before I tension my MPFL. And I want this MACI implant to be in there before I do anything. So now basically everything is done up to the MPFL part. So for doing the MPFL, and I have videos on VJSM that show this technique, just for the MPFL. I basically make an incision around from the 9 o'clock position, or in this case, 3 o'clock on the patella and up into the muscle to get into layer 2. I think one of the keys is making sure you stay vertical up until the point that you're down past in layer 2 before you get into the synovium. So I go into the muscle a little bit of the VMO, and it helps tell me that once I get through that muscle layer, I can start diving more medial towards the epicondyle to develop this layer. Now, when I do this to a small incision, obviously I don't have all this exposure, but you still can, clear this plane, and I would just have a skin incision that sort of match the length of that plane. But now I can open it up with a Metz and make sure that we get all the way down towards where Schottle's point is, and you have a nice full layer that's going to open up and then be closed. And I use a Kelly to open it as well, just to make sure that my MPFL graft is going to glide smoothly in that area. So you can see you've got a nice layer and it's protected. If I was doing a MACI from a medial exposure, I would then do my arthrotomy at this point after I develop that plane. This is now exposing the medial board of the patella. I use anchors to fix my graft. I use a semi-T graft that's been whip stitched on both sides and attached to 2 basically knotless push lock anchors that can be placed into the patella at that, in this case, it's 3 o'clock and 1 o'clock position. I do check this under fluoro and, impact the graft with the anchors. There's a variety of techniques for fixing the MPFL to the patella, but I've found this to work really well and haven't had any issues with it. So impact both anchors by tensioning the graft to the medial board of the patella. And then I used that suture that was whip stitched through the graft to oversew this so that it kind of covers the entire anchor spot. So I put a horizontal mattress in with that suture and tie it down, and it'll sit nicely right onto that medial border of the patella. So once this is complete, I basically just leave the graft in a Vanco soaked sponge sitting right in that layer 2 spot. I use fluoro to localize where I want to make a small other incision. This is the point where I check my osteotomy screws, so I do check that as well. I'm just trying to be as efficient as possible, so I wait until I bring fluoro in for this step. I localize around Schottle's point, make a small additional medial incision like I would if I was making 2 small incisions. I use fluoro to localize Schottle's point by X-ray, and then use this guide pin. I had sized my graft. I'm usually making about a 7.5 or 8 millimeter tunnel here. Usually after I place my pin, I just clear some of the soft tissue. And one of the tricks I use, I put a steri strip on the end of the reamer at 30 millimeters. It's hard to read these numbers, especially when you're old like me and can't see that well. So that marks that 30 millimeter mark when I hit bone, and I know the appropriate depth of where I wanted that reamer to go. I then take my pin all the way across the knee, and I'm ready to pass my graft down towards the epicondyle area at Schottle's point. I do this little double Kelly technique where I bring a Kelly down first because that's where I really saw the layer develop, and then I bring a Kelly back up, and then that way I know I'm in layer 2 as I pass that graft. And again, you can do this through a very small incision when we're not doing all these other concomitant surgeries for just MPFL reconstruction. At this point, with my graft passed down, I have to mark it. So I mark it where it's basically going to be tensioned right at the level of the bone. And then I take 25 millimeters maximum to make sure I can adequately tension and dunk this as I need to, and mark it. And then I'm basically going to whip stitch and amputate the rest of that graft so that it's bulleted on the femoral side where it's going to get fixed. And so then I just amputate the remaining portion. I place a passing suture first, just because I don't want to take any chance I somehow bugger up the sutures that are in my graft. So this is just putting in an extra suture first across the knee without the pin. So a little bit of an unnecessary step. And then I use this passing suture to pass my graft sutures and dunk that in. Now I make sure that this is tensioned really somewhere between 45 and 60 degrees of flexion. You don't want to over tension this, but this graft should dunk right into the socket. I typically check it on the by the patellar side as well, make sure the graft is tensioned, and then I tap and put in an interference screw to hold it on the femoral side. I always check that it's got good stability medially and it's not over tension. I always check that I get full range of motion. In addition, I range it before this point and make sure that my Macy implant didn't move. I repair that VMO. I typically pie crust the lateral compartment for repairing that, and the lateral lengthening is already repaired in this step. And that's basically again, the maximally invasive TTO lateral lengthening MPFL.
That was really remarkable surgery, Kevin. Steve Meyer, you have a question. You wanna ask a question? Unmute yourself, Steve.
That was very well done, Kevin. Thank you.
Yeah. Steve Meyer, you there? Unmute. I'll ask this question. Cases tonight have demonstrated fully contained lesions. What is current concept on uncontained lesion in any location, MFC, LSC, patellotrochlea? Are they eligible for a MACI, or is it a different fixation approach than fibrin glue only? Which one of the panelists want to take that question?
And I think going to Justin's point earlier, that would be definitely one that you would want to do an osteotomy to make sure you're offloading that. And then just the technical part that I'll do is when it's uncontained, I'll make sure that I just drill a small K wire and then just I'll load the 6-0 vicryl through like a Keith needle and then pass it through that spot. And so then I can secure that uncontained area just to make sure. So that would be my tip for that, but I would definitely, I would almost always do an osteotomy in that situation.
Yeah, I think that Macy is a pair, we've all done first and second generation ACI. And with with the FDA approval of Macy and our ability to use that, it makes it a lot easier because yes, you can secure those peripheral areas, but you're not worried about the cells leaking out of an uncontained area when we would inject the cells under the membrane. So I actually think it makes it a lot easier to deal with uncontained defects than it used to be.
Yeah, I would co-sign everything that you guys said. I think the only thing that I think we need to ask ourselves in these more complex uncontained lesions is not whether or not we can do a Macy. I mean, Macy's indicated for uncontained lesions, but it's, what should we be doing here? These things get very complex. A lot of these shoulder lesions kind of fall off the edges. Is it something that we should be fixing or can be fixing? Is an isolated osteotomy the right answer? So I think there's a lot of questions built into this question. But the answer is yeah, you can use a Macy. And one of the tricks that I like, if we really get stuck on these sort of shoulder lesions where there's not good fixation, if you're not happy with just fibrin glue as the fixation of choice, you can actually use the mini version of those push locks that Kevin showed. You can put a suture into the edge of the lesion and just tap that down with a little mini push lock and put a couple of them along the edge to hold it and secure it, and then use regular sutures on the other side. That is a real interesting way to get that thing to fix there if you're worried about fixation.
Well, this is great. As we like to say, this hour is always the fastest hour in orthopedics. Um, I would like the faculty to give some final comments. We'll start with Joe, then go to Kevin, and have Justin bring us home. Okay, Joe, some final comments on tonight's session and the future of this, maybe?
Yeah, I think I very much enjoyed this. Thank you so much. I do feel like always think osteotomy, always think the kind of the trifecta effect of like alignment and stability, meniscal integrity when you're doing these lesions, and convince yourself why you might not need to do an osteotomy when often you should be.
All right, Kevin, a few comments?
Yeah, well, I think I would just say that you saw a few different techniques to do some very similar things, and quite honestly, these cases aren't that difficult, even though they may seem a little more overwhelming because they have a lot to it. And I think if you prepare for them and kind of stick to the principles, they're really not that hard to do. And but when you're doing these cases that have like multiple procedures associated with them, you really have to figure out in your own head, how do you want to order what I do and what's going to make it most efficient for me? Like, Justin sort of goes back and forth, and Joe does his osteotomy first, and then the patella, and I kind of do it a little differently. So it's all about like what's going to make sense for me to make sure that I get all these steps done in some efficient way and done the right way.
All right, Justin, you want to bring us home?
Yeah, I think piggybacking off what Kevin said, I think my general rule with everything that we do that's complicated, and cartilage surgery is certainly complicated, is have your plan, go in with your plan, execute your plan. I think we can get into big trouble when we start to go into the OR and sort of have to make decisions on the fly and not have a well thought out plan in advance. So kind of piggybacking off Kevin's point, I think that's what I would say is make sure you have your plan, go into the OR, execute your plan. And if you're not sure, if you have questions, load the boat. We all have friends and colleagues, mentors, etc. Ask questions. Cartilage is tough, man. Cartilage is hard. And it's okay to ask questions and make sure that you know what you're doing before you go in, because I think the worst thing that you can do is have to change your plan intra-op or be guessing or be unsure.
Well, this was phenomenal. I want to thank the faculty and thank our sponsor, Vericel and Macy. product for supporting this series, which has been extremely popular. So I want to thank everybody and say good night.